from where it was in 1994. I kind of fell back into the field after I finished up my bachelor's degree in social work from EKU. I did not anticipate working in the field of addiction. But I was new to this area. I needed a job. So I took one at Crossroads Treatment Center. Everybody heard of Crossroads? I know back then we didn't have a lot of professional staff. We did have a blend of those who had graduated college and those that were in recovery, seeking what was called at that time CCDC. That tells you how long I've been in the field. CCDC. But I remember starting the job and being my director at the time gave me a big book of AA. He gave me a Jelinek chart and gave me a little bit of some videos from Father Martin. You Father Martin fans in here from way back, and said, go to it. You'll get a couple of days training and then you'll probably run some shifts for it. But we have come a long way. There's more, I think Tim's going to be talking about credentialing today. There's more and more of us out there in the field, LCSWs, LPCCs, LCADCs. And it's been wonderful to see. And we're seeing a lot more evidence-based, research-backed practice. A lot of people that were started in 1994 were like me, and it was AA or no way. We have come a long way in terms of looking at MAT in a whole new light. Some of us took it kicking and screaming. But now we understand that the medication has a different mechanism that it acts on. And the therapy and the medication definitely complement each other in terms of the mechanisms of the brain that they work on. So I'm going to be here. I can field questions shortly. I guess we'll all do a quick little discussion about who we are and what we have been in the field. But we run a lot of great programs at the hospital, and I'll be sure to answer any questions about that as well. Thank you.
Mike, can you remember what all the CCDC entailed? Do you remember how that worked?
At the time, there was a grandfathering period for folks who had not completed any college, but they would utilize their hours of experience and pass the exam. There was a oral exam. Gosh, that was stressful. I don't know what year they took that away. Do you remember, Tim?
It was probably around 2010.
But you had a case study and you had to defend that case study, and it was a little table there, and the people there that were judging your performance were not allowed to give you any facial expressions. Drove me crazy. I'd be thinking I was nailing it. That's already done. I was like, but afterwards, and I was supposed to even talk to you, and somebody came up and said, where do you work? That was impressive. So I knew I'd pass at that point. But we've come a long way now with the bachelor's level, CADC, and then we've got the LCADC for those with the master's. But Tim will probably be able to tell you a little bit more about all the hours that you put in for that. How many LCADCs do we have today? Very good. CADCs? Very good. People working towards one of those credentials? Very good. Well, Tim's going to impress you here shortly.
I don't know about that. Okay.
No pressure.
No, yeah, no pressure. You're already after Paul. Okay. So I'm Tim Cesario. I'm the Director of Recovery Services for Cumberland River Behavioral Health. One of the other hats that I wear is I'm the current chairman of the Kentucky Board of Alcohol and Drug Counselors. And for the past year, I've been the chairman of the International Certification and Reciprocity Consortium, okay, which is the organization that does the testing that everyone takes to become a CADC or an LCADC. The third hat that I wear is that I'm also the chairman of the Kentucky ASAP board, which I've been for just about 2 years now. So as you can see, I wear many hats, which is probably a good thing because I'm starting to thin a little bit. Okay. But, this whole panel is supposed to be on treatment, and I heard Mike's story at another conference a couple of weeks ago, I guess it was last week, and his experience coming into the field. And my thought, whenever I was thinking about what I was going to talk about today, was that in order to have a good treatment program, you have to have people that are credentialed, people that know what they're doing. So my original title for this was 2001 Credentialing Odyssey, but I figured a lot of people wouldn't get it. And the reason I picked 2001 was because that was the year I moved to Kentucky. When I moved to Kentucky, I was a CAC diplomat in Pennsylvania, which was an advanced alcohol and drug counselor credential. And I was not real happy whenever I found out that there wasn't a reciprocal credential here in Kentucky. But, you know, I became a CADC and, you know, I was happy with that. But I wanted to go through a little bit of the history of credentialing in Kentucky. And one of the reasons I asked Mike about the CCDC was because prior to 1996, that's what we had here in Kentucky, but I wasn't around then, so I couldn't give a whole lot of detail. And Mike did, and what you heard was people got to use a lot of lived experience to put towards their ability to get the credential. From 1996 to 2015, there was a CADC, that was it, okay? The CADC is based on the credential of an of an alcohol and drug counselor with the ICNRC stipulations or standards, okay? We had that in Kentucky for, as you can see, close to 20 years. And funny thing happened back in 2014 whenever Medicaid expansion took place. When they released the list of approved providers, the CADC wasn't on it, okay? There was some work that went into getting the CADC put on it, but in the meantime, I know that was right around the time that I came onto the board and Jeff was the chair. And our first meeting, the discussion was about trying to get somebody to sponsor legislation to create licensure, which was the advanced alcohol and drug counselor with the ICNRC standards, and that's what our LCADC is. Okay. In 2015, our credentials expanded. We didn't just bring in the advanced alcohol and drug counselor or the LCADC. Okay, but always happens to somebody, and usually it's me. So in 2015, the credentials expanded, and what we ended up having was the certified alcohol and drug counselor, the licensed clinical alcohol and drug counselor, and the registered alcohol and drug peer support specialist. Okay, and that's a person that, you know, with 2 years of sobriety at that time, was able to get into the field a little bit earlier. Okay, but along with those, you know, one of the things that we had in discussions, and Jeff, feel free to chime in if there's anything that I leave out, but we knew that for the previous 20 years, there was really no way of keeping track of how people gained their supervision, or if they even actually did supervision. So one of the suggestions during that process was to create temporary credentials, such as the temporary CADC, the LCADCA, and the temporary peer support specialist. And that's a lot of letters. Okay, so that's how those all came into being. So basically, we have our full credentials and we have our training credentials. And so in 2020, there came some changes to the requirements for all those credentials. One of with the registered alcohol and drug, or temporary registered alcohol and drug peer support specialist, the amount of sobriety was reduced to an hour or a year. Again, it happens to somebody. All right. But we also had tiered supervision, and it created, I'll talk about that in a minute, but it also created these two credentials, the CADC Associate 1 and Associate 2. Okay. The requirement was reduced at that point to where a person did not have to have a college degree anymore to get a CADC. And these two credentials gave them a pathway to go from being a peer support specialist to becoming a CADC through these two credentials. All right. Now, to become a CADC, the basic requirements are 300 hours of education, okay, 300 hours of supervision, and 6,000 hours of work experience, which is 3 years. So a lot of what, you know, a lot of what goes into it, it's a long drawn out process. There's a lot of time that it takes for somebody to learn how to practice as a certified alcohol and drug counselor. In the most recent edition of our administrative regulations, there are some there are standards that in the scope of practice, or standards of practice, that are associated with every one of our credentials, and it spells out what each credential can do. A lot of what the associates can do is going to be co-therapy, okay? Working with somebody that's fully licensed or certified rather than being able to work independently. And that's important. That's a good thing because it gets people the opportunity to gain hands-on experience. Not only that, but you have a supervisor in there with them, showing them, talking to them, processing with them, and helping them develop the skills they'll need to practice. Okay. So the tiered supervision is one of the things that came out of the legislation in 2020. What that did, like initially whenever the LCADC came into being, the board wanted to require 100 hours of clinical supervision for the LCADC. And we had our regulations written and everything, and we got on a phone call with IC and RC, and they said, well, that sounds good, but it won't be reciprocal. Why not? Well, you're not doing enough supervision. Our standards say that it's 300 hours. So we had to rewrite everything, and they to have the 300-hour requirement in there. In 2016, sure as God made little green apples, IC and RC reduced the requirement to 100 hours. So we either gave them a really good idea or we just missed by a year. I'm not sure which it is. But with the tiered supervision, again, the clinical master's degree of 60 hours or more, 180 hours of education, 2,000 hours of work experience, and you're eligible to become LCADC. For a CADC, if you have a clinical degree, that the number of supervision hours is reduced to 200. Okay, you still have to do the 300 hours of education and 2 years of work experience. And for a non-clinical bachelor's degree, or someone who becomes a CADC through the Associate 1 and 2, they still have to do the 300 hours, the full amount. And again, this is a good thing because they'll have a lot of experience and a lot of supervision that they go through to help them practice competently. So 2021's legislation brought in the licensed alcohol and drug counselor. Now, you've heard me talk about the LCADC being an advanced alcohol and drug counselor and the CADC being just an alcohol and drug counselor. The LADC is also an alcohol and drug counselor, but what that L does is it designates that person has a master's degree, okay? The LADC is in place for someone who has a master's degree, but might not meet the required number of hours, okay? In other words, it's a master's degree of less than 60 hours, okay? The other thing that was really interesting is we were able to get a new credential approved for supervisors, which is going to be called the Certified Clinical Supervisor. Okay, that's also an IC and RC credential. We ran into some problems whenever we submitted the regulations to get the grandparenting period established. It was questioned whether we had the authority because of how the original language was. But I'm happy to say that in the last legislative session, Senate Bill 178 corrected that. We have a meeting tomorrow, and we're going to start working on identifying what the 1 year window will be for people to grandparent into that credential. What a certified clinical supervisor, to get a certified clinical supervisor credential, there's a lot of work involved with that. I believe it's around 200 hours of actually providing supervision. It's 10,000 hours of work experience. Those are the basics of it. You're going to have to put your work in to get that credential, but it's going to be worthwhile because all of these credentials show proficiency. They all have, to get any of these credentials, you have to pass a test. Okay, you pass that test, which is it's psychometrically sound. It's formed after a job analysis with subject matter experts that develop the questions. There's quite a vetting process for these tests. If you can pass the test, you know what you're doing. And that's always a really important thing because remember, the credentials that the board offers, we're through the public protection cabinet. Okay, so everything that we do, we have to make sure that the public is safe whenever one of our practitioners is providing services. Well, I just talked about the certified clinical supervisor. This is, I think, the last substantive slide that I have. These are the credential holders in Kentucky. When I came onto the board, I think we had less than 1,000. I think it was around 900. Okay. Today we have 3,089 with all the different credentials that we offer. You'll see that the biggest one is the temporary CADC. And one of the things that I have to say to qualify that is there are some people that still have their temporary CADC, but they're not eligible to practice because they're not under supervision. Okay? But they still have it. And that's something that we're working on to try and track that a little bit better. So the summary is the changes to the Medicaid spurred the increase in the number of credentials offered in Kentucky. Changes to the credentialing have required that people show proficiency in the field of alcohol and drug counseling. And credentials such as the registered alcohol and drug peer support specialist give people the opportunity to get into the field earlier. 2 years of recovery, a year of recovery now, and they're able to get involved and try to help people. And I think that's a good start on a career ladder that can really strengthen our field. And I just gave you that number at the end. And I wanted to also acknowledge that Billy Noble, one of the former board members that was here through a lot of this change, is in the room. And, thank you for everything you did, Billy. Thank you for everything you've done, Jeff, because you guys have both been leaders in this field. And with that, I'll hand the clicker off.
All right. Good morning. We're still good morning? Yeah, barely. So I'm Jonathan Gay, and I'm an attorney with Addiction Recovery Care. And so just a quick introduction about myself. I grew up over in Les Lane, Clay County, and I began practicing law in 2002. I worked with Warren Scoble, actually in London, from Judge Pruitt and many other judges. And when I started clerking for Warren in 2000, one of the first things he did is send me down to the local jail, start meeting clients. He would call it PRing clients. And so I would go down, and so that began my career working with people in addiction. I'd grown up and seen a lot of that in my community already. I worked with Warren for a couple of years, and I went to Morehead State University. I continued, though, while I was at Morehead State working with small businesses, I continued doing criminal defense on the side. So I've maintained that path for about 20 years now, continuously working with people. And over the years, this won't surprise you, Judge Pruitt, that probably 95% or higher have been substance-related cases. You get a burglary, you get something occasionally, but most of the time it tracks back to addiction. So I have worked for Addiction Recovery Care since 2018, I believe. I've been full-time with them, but I've watched the company grow for many years by a law school classmate of mine by the name of Tim Robinson. So I'm excited as soon as these fellows can get our slideshow up to run through an introduction to you for Art. So I don't know what can you get the slide up for Addiction Recovery Care, please, Jonathan Gay? I attempted to email it in advance, and it was too large. Yeah, she loaded it on there. So while we're waiting on the slideshow to pull up, I want to give you some stats about the company. Actually kicked me off where it was. So give me just a moment. So a little bit of introduction about Addiction Recovery Care. We have nearly 2,000 patients at the moment. 1,100 of them live with us. That number doesn't go down very much. We have generally over 1,000 people that are living with us at any given moment. Billy, any of this that I get wrong, your job is to correct me. 200 of those 1,100 clients are interns. So those are men and women who are in early recovery, usually at least 6 months of recovery, who continue to work with us, who begin working with us rather, and work with their fellow men and women who are in recovery to try to help them in their early days of treatment. 800 of the 2,000 are in outpatient, 900 full-time staff, and that full-time staff includes 200 people who are interns. So 700 professional staff, I guess you could say, and 200 people who are working on pathway to ultimately get employed by us. You guys still have that? I've got the jump drive.
Yeah, what's the name of the file?
What's the name of the file?
It's a good question. I'm sorry.
Okay, no, just let me know.
It was self-evident. It was art, recovery. It wasn't anything fancy. We started out though in Louisa, Kentucky, and that was where Tim Robinson was at the time the assistant county attorney in March County, and he was what he would tell you is a barely functioning alcoholic. I've heard him characterized at other times, man, as a fall down drunk. And those of us who went through law school with Tim had watched him progress downhill for a long time, and Tim had a faith experience. There we go. So let me pause that till I get to his slide. I hope I didn't hit the wrong button here. Okay, so here's Tim Robinson. So Tim is the founder and CEO of ART. He had a faith experience at the prosecutor's desk with a local bailiff. Local bailiff brought him to the Lord, and he realized, look, the life I'm leading is not a good life, and it's not a fulfilling life, and it's a life that's ultimately going to end tragically if I don't turn things around. So sobriety date of 2006, 2008, he completely resigned his practice as a prosecutor. Up until that point, Tim had been doing what he calls transport ministry, where he'd been taking men and I guess women, if he had a chaperone, to treatment and all these treatment centers. And he realized, look, we didn't have enough treatment centers in Eastern Kentucky. So he opened up what's called Karen's Place, and Karen's Place was a recovery center for women. The only confusing thing about ARC is we name each of our centers a little differently, so it can sometimes get confusing. But Karen's Place was our first center, and we opened that in 2010, and I'm proud to say that the first patient through the door still works with us, Vanessa Keaton, and just a terrific person to work with. I talked to her yesterday. So here's our career progression, if you will, of ARC. 2010, I already said, Karen's Place. 2015, ARC admitted the first Medicaid client. Tim says, the good news is we were the first in with Medicaid. The bad news is we were the first in with Medicaid. So we had a lot of really to work through, but we survived and thrived. 2016 created a vocational track, and I already ran through the numbers where we are. We're in 21 different counties in Kentucky, still just in Kentucky, but we're very close to Virginia and Ohio, so we're excited about that. Here's our map, and so we're as far west in terms of residential centers as Washington County. We've got an new outpatient program in Louisville, and I understand we just closed on some property or imminently closing on some residential property in Louisville, and we're also working on a place over in Owensboro. So we footprint, a lot of cats to herd. Our motto, one of our mottos, rescuing thousands, one life at a time. We believe in loving each and every person that comes in our door, regardless of what they look like, regardless of their sexual orientation, regardless of gender, regardless of any possible characteristic that you can think of. We try to love them back to life and show them the kind of care and dignity that we think they deserve. So we take a holistic approach to recovery. Recovery opportunity is big. You have to give folks not only the motivation, but you've got to give them those assets that they need to keep their recovery. Physical health, emotional health, and of course, spirituality. You know, I talk about the fact that we love any and all people, but we're very much centered on Christ, and that's our focus. We have 4 phases. So phase 1, where you just come in, withdrawal management, you're just getting yourself grounded and starting to begin over. Phase 2, we start introducing some recovery skills and some case management. Phase 3, recovery in action. We start looking at, what do you want to do? Are you going home or are you going to stay? Unfortunately, the answer too often is, well, I'm going home. I think I'm good. I'm cured. I'm going to go back. I'm going to live in the same house, live in the same apartment, same people. And unfortunately, that doesn't always work. Phase 4 is the intern process like I described to you earlier. That's where folks stay with us up until 1 year of recovery, and 1 year on, we do as much as guarantee them a job as we possibly can. I don't think we've ever had to just push somebody out the door. We occasionally have somebody that just doesn't work out. But of all the hundreds of people that come through, almost each and every one of those folks ends up working with us and staying with us if they go through that internship program. This is, am I getting close to 5 minutes? This is Crown Recovery Center. This is our crown jewel. And this was a small Catholic college campus in Springfield, Kentucky that our partners purchased and we lease. And we are very proud of that. Love to show you that sometime. An aerial view of Crown Recovery. Beautiful, beautiful facility. And Billy, we've got over 500 clients on that campus. Yeah, so I mentioned about 1,000 residential clients. Half of those folks are in one campus in Springfield, Kentucky. 40,000 people have completed one of our programs since we opened the door in 2010. I mentioned already that we take Medicaid, but we also take private insurance plans. And we occasionally get folks to come in out of state. Drugs of choice, this is an interesting one. We're seeing that opiates remain high. Unfortunately, we're seeing the transition to heroin and fentanyl. I was joking with the prosecutor recently. I got a case, and it was a possession of oxycodone, I think. And I said, she deserves a medal, not a harsh sentence, because we've got an oxycodone. Everything we're seeing is fentanyl and heroin. And of course, it tracked back to, it was a 2012 case, so she had a bench warrant that had eluded her for many years, or she had eluded the warrant. We are seeing a lot of methamphetamine. Synthetic drugs are on the rise, and I think they're going to continue to be a bigger and bigger percentage of the population to treat. So spiritual decisions, 997 first-time decisions to follow Christ. This is just in 2021. Over 1,000 rededications, over 1,000 baptisms. 900 plus jobs created. That's 900 plus jobs that we have currently. And of our workforce, I'm proud to say, half of our workforce, if not a little higher, are in recovery. And a third of those employees are actual graduates of the program. And they're not just simply, doing the small work. They're taking on senior level positions in the company. They're working their way up. So it's the number 2 person in the company is a graduate of Belgrove Springs, Matt Brown, and we see countless stories that Vanessa Keaton I mentioned earlier, just people who come and stay and work with us and have really meaningful careers. We did start a college that's new, and it's fascinating to see that. We're trying to get accreditation with our Millard College currently, but we already have programs for peer support specialists, addiction recovery care studies, and behavioral health techs. Internship programs. So here's just a quick rundown of the kinds of internship programs that we have. Not everybody wants to be a peer support specialist. Some of these folks want to work in different industries, so we try to honor that to the extent we can. 6 CARF accredited areas: residential, partial hospitalization, detox. We just purchased Our Lady Bellefonte, where we're going in a psychiatric hospital and a medical detox, which would be new to us. So I think I'm almost at the end of my row. 180 Karen's Place Maternity Center. We've had over 180 babies born in the past 5 years. And the great thing about having a baby that comes through, with their mom comes through recovery, is they don't stay in the NICU, which is good for the baby, it's good for society, it's good for the taxpayers. Just a snapshot of some of our stats, 180,000 eggs consumed. So, yeah, it's a lot of eggs. I just want to leave this, and I want to encourage you, if you've never been to an addiction treatment center, come and see one. Come and get a tour. I'll personally give as many of you a tour as I can, but if I can't give you one, then I'll get someone at the various programs. You saw our footprint. We're in a lot of places, and I would love to introduce you to ARC and our model. So that's it. Thank you, and I look forward to your questions.
Thank you.
I was trying to say, I just happen to know, Dr. Walzak touched me in here, and I'm just sharing what we do on campus and how we do referrals. So please He can take his time and you guys can go. Okay, good. Okay, good.
Okay.
I was gonna be so
Yeah,
short, is what
I
I was
agree.
saying, if I was offering any time.
I'm Kyle Perkins. I'm the Executive Director for Horizon Health. Jonathan, I don't know how I followed that. It's an amazing story and one that we're all proud of for you. We too are an addiction treatment and recovery center. We now have a model that we can shoot for, but our folks work very, very hard in doing the same thing. It's really interesting to hear the faith-based foundation that you have. I think we have the same. Our folks are all dedicated. Everyone needs care that comes to our door, and we don't want to discharge anyone. It's about keeping them in the program through to recovery. I'm actually a CPA, so we have a lawyer and a CPA. We're due. I actually came to be involved with Horizon Health. I was actually a consultant. Horizon Health was a client, and the board of directors needed kind of a mission. They needed a direction. And they came to me and they said, hey, there's a lot of things going on in addiction here in Southeast Kentucky. We'd like to see if there's something we could do to help. So I went to work on that, and fortunately we had a grant from the Health Resource Service Administration, planning grant. So we used those funds to support the planning activities. And we came up with what we look at as a whole person approach, something you all know about, towards providing services that meet the whole person's needs and doing that in one location. So before I get into all that, I do want to recognize our people who are here. And I told them, I said, look, if I get going, I'll talk about Horizon Health all day long. So I empathize with Dr. Mooney and everyone that sat through that. But such great stuff. But joining us today is our Chief Operating Officer, Monty Sears, our Director of Community Engagement, Rhonda Hughes, and Ashley Jackson, who's now taking over our intensive outpatient program in housing, and Skylar Cole is manning our table. He's our Director of Information Systems. As well, we have a group of our targeted case managers here. So we've kind of descended on you to learn everything that we can about what our folks have to say today during the program. So I'll get started as soon as we get in here. I guess Horizon Health, we have campuses in London and Williamsburg. On campus, we provide medically assisted treatment through our MAP program. That's coupled with our behavioral counseling, both individual and group. We have CLIA certified laboratory services, so we use analyzers. All persons coming in for their appointments are required to do a UDS. That's immediately transferred over to our EHR system for viewing of our counselors and providers during that point in time. On campus, we also have, we're a licensed daycare facility. So it's something that we're very proud of. If you think getting licensed as a BHSO or medical facility, try getting licensed as a child care facility operating within a MAP program. As far as we know, as far as we know, we're the only ones like it in the country. It's a barrier to care. A lot of times, patients will avoid, or clients will avoid coming in for their appointment because they don't have a sitter, or they don't want to, fool with bringing the children with them. On the recovery side, back to employment, a lot of times, they'll get a job, client will get a job, but then face that child care barrier as well. So it's a great program. Our leadership team has got it now to where it's self-sustaining, and we hope that continues. So when a patient comes in, flip back and forth, but when a client will come in, if they so choose to bring their children, we can take them to a secure area facility where they can wait the hour that they're in the clinic. Another interesting thing about our program is our new matrix, our model for scheduling. Another barrier for care, of course, is transportation. How many of y'all heard that? I mean, I think everywhere you go, it's like transportation is a problem. So what we've done, many of our clients rely upon a family member, a neighbor, or someone, to help them get to their appointments. Last year, we introduced what we call the scheduling matrix. And when you come into Horizon Health, in the first 8 weeks of the program, you'll be given a static day and time to be there. After you played out of that first 8 weeks, we just reschedule you around because now you're on a 2-week program. So what that's done is to stabilize for the client. They know exactly when to be there every week. As a result, our no-show rate has dropped to 15%, which is amazing. If you look at that statistic in a clinical environment where MAP services alone are provided, and then the client is expected to reach out to find behavioral counseling someplace else, those numbers can go as high as 40 to 60%. So we're very proud of that statistic. So that's a little bit about kind of our services. Targeted case management is key. Counseling, our entire group acts as a team. I'll get into that in just a little bit. Yes, sir, thank you. I won't get into statistics, but I did want to put some up here just for you to look at what happened. I think we've all heard enough about what happened. How did all this happen in 1990, the 90s? Drug companies were telling providers that these were safe and effective. And then 20 years later, we had 33,000 deaths as a result. And then that number doubles to 2019. And then it's even gone up, as you know, if you keep up with those statistics. So just in a short period of time, we have an epidemic. So from there, what do we know now? These are some of the things that we've learned as we've gone through dealing with this crisis. In the last 2 years, we've probably learned a whole lot more. We can get into that a little bit with telehealth. But the way I've described the opioid crisis in persons affected with OUD this last couple of years, imagine being involved in an epidemic that's now wrapped in a pandemic. So we really saw a lot of problems come out of that, and trying to keep people engaged, keep them in the program. Telehealth helped with that. One of the things that I saw in Jonathan's slide was the rise, in other stimulants, other drugs. Our on-site labs have helped us identify very quickly if that's the case, and then we develop programs, especially in counseling, to address that. So in 2020, HRSA was asking us, are you guys seeing the same kind of rise in meth use, to pick one, that we're seeing across the country? We did some analysis. Yeah, we're seeing the same thing. And so we developed some cognitive behavioral therapy programs. And by the end of the year, we were at our lowest levels for that polystimulant. So what are the issues with an integrated system of care? This is kind of what we came up with in our planning. These are the issues that our folks are dealing with. You've got clinical care, behavioral issues. Just get that. Behavioral issues, social issues, physical environment. Jonathan, again, you touched on that, but going back to the same place you came from. So all of our staff are very focused on recognizing those issues. Safe housing is one. Domestic violence, are you dealing with that? And from those analysis and those discussions with clients, we can develop counseling programs. We can develop ways to address that, and it's been very successful from our case management side, from our counseling side as well. So the interesting thing that I found out in my research was that the issues that are unique is that I think the number is 55%, pardon me my glasses, 50% of family members, when you talk to the families of persons who are addicted, 50% of them would reach out to help find treatment. Interestingly enough, only 5% of referrals actually come from healthcare providers. And look at the bottom. Judge, that's 44% is coming from the legal system. So, that's how you have to start to look at your program. Where can we find people who are in need of our services? And then develop programs that work with family members, which is very important to address the problem that our clients are facing. Yes. So we developed an integrated system of care, which is now becoming kind of commonplace. We look, as a behavioral health service organization, we take that very seriously. And we look at the MAP component, or that clinical component, as just part of the program. So our administration and our counselors and our providers, we continue to keep them focused on the fact that you're just part of the program. Now, we all know that in a clinical environment, many times the providers take the lead. We've developed over the last couple of years interviewing processes. Addiction medicine is not always perfect or a perfect fit for some providers, right? So what we do is we look for those providers who are truly dedicated to addiction medicine, because the whole program really relies on them, but we bring in folks who are sensitive to working in a team environment, and that's what we develop at Horizon, so that when we, every week, Rhonda Hughes, our community engagement person in compliance, we hold a patient care team review meeting, Zoom, and so everyone in the organization is on that, and we talk about specific clients who may need support. Barriers to care. Folks in this room know what they are. This is kind of the brick wall, if you will, that a lot of our clients face. And these are the components of that. Geography, especially in rural southeastern Kentucky, right? That leads to transportation issues, economic issues, so forth. During the pandemic, we really found that telehealth was a terrific way to support our clients. Now, a lot of them maybe don't have broadband access, but we worked very hard through telephone and internet to connect with our patients, and I think it really helped us continue to grow the program. So these are some of the advantages of telehealth. Of course, it really is a transportation barrier. The big thing we found that in the world of COVID, control of infectious illness, that's a big plus. Disadvantages. I don't want to tout the whole thing is all great. There are some issues that have to be overcome, but I think the last couple of years, the regulatory agencies have been very, very helpful in assisting with removing some legislative barriers or compliance barriers for us. This slide gives you a really good picture of what I mean when we talk about an integrated system. A lot of times integration, in my experience, has meant, well, you partner with outside agencies, which is really, really strong. It's a good way to go. We try to bring all of those things out of different silos and put them into one campus. Okay? So everything you see here is what we offer on one campus location. From medically assisted treatment or counseling, our program compliance, and then other services, which is, of course, I mentioned childcare a moment ago. We just opened this week our women's housing unit in Williamsburg. We're very excited about that. It's a 15-bed facility, and it couples with our IOP program. So that just opened, thanks to our leadership team back there. So here's some opportunities for integrated healthcare. I can't list them all, and I could go on and on about some of the advantages that you have with an integrated system, all in one place. I always refer to this when I talk about an integrated system. My guess is nobody in this room had any trouble getting to Barberville. Imagine waking up in the morning, no idea how I'm going to get to my, buy groceries, how am I going to get to my appointment? Those things just don't enter our minds. So what you want to try to do is to, and what we've tried to do is to make everything as simple on the client as possible. So when you show up at one place, everything's there. In our London campus, for example, local healthcare provider, Grace Health, has just opened a primary care center and a 340B pharmacy. We have neurotherapy, another business in the same building. So everything's right there for the patient client there. So just to kind of a review of some of the things I've talked about this morning, and we can talk further about that in the discussion session. So thank you very much.
Thank you. Those of you in the room and your expertise are like, how in the world did she get plugged in here? I know her role from this morning. But Dr. Walzak asked me to join this panel and just to share a little bit about what union does. So I don't know if any of you all are wondering, well, how do we take care of our students? What kind of needs do we have? How do we handle those needs? And our psychology faculty, Dr. Vasilescu, is with us today, one of which, and we have a fantastic group of credentialed faculty here that, in addition to teaching and all the other responsibilities they have to do from the college perspective, they use their expertise and credentials, and they offer counseling services to our faculty, staff, and students. And they can tell you, many of them are up late at night working and dealing with issues. But what I wanted to share is, again, when I introduced myself this morning, is my background is nursing. I have a doctorate in higher ed leadership, so I kind of went south or east or west. So I started talking with the psychology faculty, Dr. Walzak, primarily, and the counseling is wonderful, but it's one part of many treatment plans, as you all know. So she reached out to me and said, I need help, but I don't know where to start. And I was like, I do. So I reached out. I've had contacts at Baptist, worked there in the 90s, did clinicals, still have lots of great people in great places, and reached out and said, once my counselors here really feel like that person needs that next step, they need a referral to a provider, they need that additional help, what can you do and how can we work this out? Not knowing, I don't live here in Barberville. Full disclosure, I live in Corbin. I know what's available in my community, but I'm still learning Barberville. Made the call, made the connections, and they're like, oh, we have a psychiatric nurse practitioner over on Knox Street. And I said, by Dairy Queen? She was like, yes. I was like, okay, I know where that's at. So the moral of the story is we worked out a contract agreement. And another thing that happens is students that are still under mom and dad's health plan don't always want mom and dad to know that they've received services. So if you all in this room deal with insurance, I have a daughter in law school. She goes to the doc in Florida. Guess what I get? I get the mail to the home. So what we have done for union is, whether from our students, if you have insurance, but it is a confidentiality situation and they have not shared it with their family, we cover that visit for them. If they do not have insurance, they can be referred and we cover that visit for them. So Baptist was great about the billing. They deal with other colleges and universities, and they knew exactly what I meant. And when I was like, well, can we work something out to where that insured student can still have that confidentiality if they want it. And so we've got a special way that they have to check in when the billing comes through, and it comes to us versus their family. We all know, once you're over 18 and confidentiality and all of those factors, but that is a side to the insurance world that once she said it, she was like, their families are finding out. And I was like, yeah, their families are finding out because the EOBs are going to the home address under the insurance. Yeah, I got that. So I was very grateful to the team at Baptist, and we went back and forth and worked out that arrangement. So you're here on our campus today. Earlier, I think in this room this morning, we were watching the presentation, and the teenage and young adult, well, that's who's here, and that's who we serve, and we do everything that we can to take care of them. So I've always been real appreciative to my faculty here in our psychology area, because as we said, and several people have kind of repeated throughout the morning, is the pandemic did nothing but make matters significantly worse for this population. And so I'm really glad that I was able to step in, work something out to where once they need that next step, that we're able to provide it. So I'm not a treatment professional, and it's wonderful all the things that I've learned here, but we just wanted to make sure that our students had a route to that. So I tell people, they're like, oh, I'm really sorry to ask you that. I know you're not a nurse. And I said, no, I'm still licensed. And I still do my CEUs, and I still do that side of the house. And so it's amazing the times in my position when having that knowledge and the connections that matter. So, and I realize that I'm like, the Q&A session is before lunch, so I'm going to sit down because it's not a good place to be when you're at a conference. It's right before lunch. So, but please, like I said, I've learned so much today, and let's have if there's any questions, and then I'll turn it back over to you.
Does anyone have any questions for any of the panelists?
Give you all talked a little bit about telehealth, and certainly there's a place for it. I wonder if we found what that place is yet. I worry that some folks will go to a model that that's all they use, and we know that for every patient that's not going to be the right fit. So I just wonder if any of you could comment on what your advice is for us at the state level as we look at this. How do we manage this where providers are so heavily on that it hurts patients?
Can I take that? Sure. Because you really hit on something that I think is really important, and it's a great question. What we do is we use telehealth as a support means, staying in touch with a patient. There's nothing that I guess the need to see that person face to face is critical. I think everyone on our care team will tell you that. But there are occasions where a patient may not be able to come into the clinic for a real reason. So we use that as a support. Weather is an issue. So we're able to connect a provider, a counselor, even a case manager with, a patient. We do not really, at Horizon, we don't like the telephone method. We like Zoom, we like Teams, so we can see what's going on. So I think a hybrid system really works well, but let's not move telehealth to the main, means of communication with this patient population, because it'll just become too easy. And it is a difficult process. So I think, what we found is these people need human interaction. Many times, they've gone to almost a reclusive position. So it's I think it's an important component, but it's a tool. I guess is the best way to say it.
I really hope it sticks around. Until every small town has all the levels of care, it's going to be critical. And we use a hybrid model as well, but it does take away that transportation issue. If we tell you you're going to have to be on site one day out of the 4, they're able to pull that off much easier than trying to arrange that 4 days a week. And we always do find a way to help them with transportation. We've been able to widen and get those folks that typically we could not, and it's been a blessing.
Any other questions? I've got a few to, yes, ma'am.
I would like to know, I know it's lunchtime, but for Horizon, I'm sorry, I forgot your name.
Oh,
but I'd like to hear more about the CBT program that lowered the meth use significantly.
Right. We worked with JB International, which was a free consulting group that HRSA provides. And it gave us access to a lot of professionals who've been dealing, in this industry or this care lane for many, many years. And so we turned to our counseling group really and asked them to design a program that in the cognitive behavioral realm that address specifically the meth use. You know, why are you using this? What are the triggers that affected your use? How do we manage you out of this? What we found really was that it was truly those factors of environment, you know, the fact that COVID had driven people really further into that reclusive, you know, position. So, you know, as a non-professional counselor, I can't give you any more detail than that. I look at this, you know, the statistics and the summaries, but we'd love to get you with one of our counselors or TCMs who are here that could help more detail about what that program actually looked like. But I can tell you it was very successful. It was exciting to report by the end of 2020. Yeah, by the end of 2020, those levels had gone down to the lowest level, and we saw the spike, you know, that everyone saw across the country with especially meth use. And by the time we got the program implemented, we got people into group. Some of it was group therapy, and they were able to share their stories. I like those environments. Thanks for the question. I hope that was a little bit.
Thank you.
Any other questions before we wrap up?
Jen, this is for you. I'm graduating in December from Union. I'll have my master's in substance use counseling, but where can I find, because I want to do my life like the LADC or the LCADC. Where can I find somewhere like that breaks that down to where it shows? Is it on the ADC website?
The actual, you'd have to look in the regulations to get the exact numbers on it, but if you give me your email, I can send you a paper from ICNRC that has it all outlined.
Yeah, I'll do that. Thank you.
Anything else? Well, thank you very much. You guys have been great. Enjoy lunch. I'll talk to Chris.